This is LiveWell Talk on the new bone clinic at UnityPoint Endocrinology, Diabetes Care, and Healthy Living Clinic. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's Hospital. The new bone clinic will work with patients who have metabolic bone disorders, low bone mass, thinning bone tissue, and people who are at risk for those conditions. Joining us today to share more about the clinic is Abby Crow, a nurse practitioner at UnityPoint Clinic, Endocrinology, Diabetes Care, and Healthy Living Clinic. Abby, welcome to the podcast.
Thank you,
That's
Dr.
a big
Arnold.
title. UnityPoint Clinic, Endocrinology, Diabetes Care, and Healthy Living Clinic.
Yeah,
That's
lot
a
of
lot.
different things that are happening
Yeah.
there. We have weight loss management, general endocrinology, a lot of diabetic management. But in addition to that, there's a health coaching program and a number of dietitians that work with us, diabetic education. I mean, it's a huge center for a lot of the components of healthy living that help improve everyday quality of life.
Yeah, we've had Sister LaDonna on and some other experts from over there. But you've started this bone clinic, which is kind of code of the doctors we hear osteoporosis. But tell me the services that you're going to provide.
Yeah, absolutely. So I'm board certified from the Bone Health Osteoporosis Foundation in fracture liaison management, which means for individuals that have had low trauma, no trauma fractures, I'm there to help support their recovery. In addition to that, though, I'm board certified in clinical densitometry, so I can interpret and review DEXA scan results with people, discuss the multiple societal guidelines that have to do with the treatment of compromised bone density, and how to reduce risk for fracture in people who are moderate to high risk to very high risk.
Now, the osteoporosis, at one time, you had calcium, vitamin D, and Fosamax. And I've probably exhausted my knowledge of osteoporosis just with that trilogy. But tell me, what are some of the new ways to treat osteoporosis?
Yeah, absolutely. Well, Fosamax is definitely the one that everybody thinks of, right? It's been on the market since like 95, tried and true. The new models really suggest that in the high-risk people looking toward more of the anabolic therapies or the new therapies that have come on the market since the 2007 and newer time frame are the right direction to really help rebuild the bone. Fosamax is a fracture risk reduction agent that helps to seal and protect the bone, but it doesn't really build bone a lot. And some of the newer technology has really been shown to more aggressively do that. And then still to follow that with the nutritional aspects of things that we commonly don't think about, right? Calcium, vitamin D is pretty straightforward, but protein plays a huge factor, trace minerals, magnesium. Rarely we do see some phosphorus deficiency, especially in our population here where we have, more people of European descent. And so there can be other metabolic factors that come into play. We have people who have high-risk medication usage as part of their regular health maintenance.
Oh, yeah. I hadn't really thought of that. Yeah, that's right.
Steroids, diuretics, seizure medicines, absolutely. So there's a number of those very commonly prescribed medications. In addition to that, hormonal medications, Depo-Provera, we know so much more about that than we did a decade ago. The PPI or H2 blockers that people take for GERD, very common, Proton. Pepsid, those types of things, they can also interfere with, bone building. The mechanism isn't really well understood, but we know that it certainly interferes with that. But in addition to that, it makes Fosamax pretty much, obsolete. So 1 in 8 people on the Fosamax isn't going to respond to it just because of absorption issues.
Yeah, and the sitting upright.
100%.
After.
But not only that, but you can get profound, esophageal problems.
Oh, yeah. I've seen
reflux.
a couple cases over my career where they had esophageal erosions from Fosamax.
And that's really what the newer agents are targeting. They're targeting the people who are not a good candidate for Fosamax, whether they're too high risk or they could potentially benefit from, being able to bypass the GI tract and able to absorb medication better.
Now, one of the concerns of osteoporosis, much like high blood pressure, it becomes a problem most of the time after it's caused some damage, right? Mm-hmm. After you have the compression fracture, after you take a tumble and break a hip, etc. Mm-hmm. So when when and how are people screened for osteoporosis?
Yeah. So, the task force says, the preventative task force that we use says 65, for women, 70 for men. So that's in people that have absolutely no risk. Anybody who has an associated risk factor, you're small, have a family history of a hip fracture or any type of major fragility fracture or osteoporosis, you're on a high-risk medication. You had early menopause. There's a long list of things that would say that we really need to start screening at a younger age. One of the big ones that we see is women who have a wrist fracture in their 40s or 50s. That's a huge red flag that there's potential for those more serious fractures down the line. Women can lose on average 2 to 4% bone mass during their menopausal transition annually. Some women, that's as much as 6 to 8%. So there's a huge swing that happens in, late
And
40s, 50s.
What percentage of loss is when you start seeing fractures?
Mm-hmm. There's not a magic number.
Okay. All right.
To be honest, more women who are in osteopenic criteria will fracture, and that's just due to the sheer number of women who are osteopenic.
Well, okay.
So
the denominator's high from that standpoint.
Yeah.
So so I'm a woman and I'm high risk. When should I get screened?
Yeah. When you start going through menopausal transition, for sure. If not before then, particularly if you've had periods of estrogen deficiency, if you're small, if your family history is really strong. For our particular insurance programming that we have here at UnityPoint, they will cover with no question at the age of 50. But if a person has gone through menopausal transition in their 40s, they need to start screening then.
Okay. All right. So, all right, that's a good. Now, you mentioned men, and that was going to be my next question, that it's not just a disease of women. Men get osteoporosis, don't they?
Yeah, absolutely. In the eighth decade, osteoporosis really becomes more of, and I don't like this term any more than anyone else, but they call it senile osteoporosis, but it means it's age-related. So when we see osteoporosis in men in their 80s, it's usually related to the fact that they no longer build bone with the same oomph. Women have that effect as well. But for men that have had low testosterone levels, for men who have been on medications or treatments for prostate cancer, for men on high-risk medications, and very commonly in Iowa, for men who have dealt with vitamin D deficiency, right? There can be interruptions in bone building and ability to maintain bone much earlier than age 70. And so again, if you have those metabolic risk factors, if there's a reason to suspect that you went through a period where testosterone was not the level that it should have been, there's risk there. And often we'll see men even in their 40s that will have low testosterone levels. If untreated for whatever reason, they may already be osteopenic, even at a young age where we wouldn't expect that.
Do men do worse than women as far as the compression fracture, and is it more severe? Is it the same?
Yeah, so the big thing is that the outcomes for men sometimes are worse, particularly as it pertains to hip fracture. They don't have a lot in terms of compression fracture data. Obviously, we see a larger number of lumbar compression type fractures typically in women, but the data from the hip fracture says that men typically have more associated loss of life with hip fracture.
When it comes to bone loss, what are some symptoms of that? Unless I discuss with my family doctor, maybe what would I stop and think about? I might be having symptoms of that.
Yeah, absolutely. So the truth of osteoporosis is a silent disease until fracture, which is a lot of times why it is hard to intervene early if we're not aware of what our risks are and what the screening criteria are for osteoporosis or potential bone density loss. With a fracture, actually 80%, 75-80% of morphometric spine fractures, right, patients have no symptoms. So it may just be incidentally discovered on a chest x-ray or during a part of another medical workup. The other, 20 to 25% will be clinical fractures. Those people will have pain and often a lot of it that might bring them into their primary care doctor or to the emergency department. Or maybe it's a small fall that shouldn't have resulted in an injury for someone that does, result in breaking a bone. Again, those are those red flag things. For people who are experiencing things like muscle cramps and bone pain and that type of thing, that can be associated with bone loss, but it's almost always due to a secondary cause. It's not generally osteoporosis in the sense that we think of it. Nutritionally, there's something missing. Metabolically, something isn't there, and that's what's resulting in that rapid bone loss. It's equally important to catch that, and so if someone is experiencing those things, it's very important that they get that investigated. I think that your question that you were kind of pulling from earlier is, at what point do we intervene? And that depends. It's very personalized. And part of what I do in my services is I go through with people what their risk profile looks like. We talk about what their screening tests have shown. Not only do I use bone densitometry, but I actually can pull from past CT scans that they've had done from different skeletal sites for something that's called opportunistic CT, which actually gives me a little bit more information about what the actual infrastructure of the bone looks like.
So you can go to an old CT scan?
I can. Yeah, I can. I like to have them within the last couple of years so that the numbers seem to probably be pretty true with where they are.
And that's just off like the scout films that are...
Scout film, or if they've had like a CT of the abdomen pelvis. The areas that we generally pull from are like T12 or L1 vertebral body. And basically we're just looking at the Hounsfield units, the reflected units there to determine, what that measurement is for that average of the region. And if the regional average is below a certain cut point, then it's more suggestive that they have degradation to the bone.
That's pretty cool. I didn't know that. Is that something...
It's a newer technology that we've started using just the past few years. Many of the bigger markets are using something called trabecular bone score, TBS. This is the most similar thing that we have to that without the additional expense of the technology, but it gives different information than mineral density, because mineral density is a great screening tool, but it's only one tool. It can predict fracture just about as well as blood pressure predicts the risk of stroke, and slightly better than cholesterol can predict the risk of heart attack. So it's a tool, but it's not perfect. So
do they still do the spinal injections, the lumbarplasty or whatever it's called?
Kyphoplasty.
Do they still do those?
So interventional radiology does them, and orthopedic spine does them in certain selected cases. The insurance coverage for it
not
varies.
Everyone benefits from it, correct?
Yeah, that's correct. For people who have persistent pain, sometimes there can be some reduction in pain in terms of duration and severity. Often it is seen as an elective procedure, though, which means that, insurance coverage for it does widely vary. And then there can also be some biomechanical limitations to putting cement in a soft spine. There's the potential for adjacent, or above or below fractures with subsequent falls. So it's a complex decision for people to determine whether or not that's the right thing for them. But they do definitely still offer it through interventional radiology and through orthopedic spine.
Because it seemed like at one time it was more, I don't know, if popular, if you will. It seems like, just...
Yeah, they used to jump to it. It was like, immediately. And now it's really become one of those things that we do try to manage people conservatively without, first. So...
one time there was a study that or hypotheses that carbonated beverages led to osteoporosis. Is that true?
I've not really seen anything that was super compelling that said that, we can clearly tie any specifics to it.
I think the conclusion was that the people in the studies were just drinking less milk because they were drinking, pop.
Or potentially they're getting less nutrition from other sources.
Right.
I mean, that's really hard to tell. Many of them could have been diabetic as well. And we know that diabetes has a huge factor, in bone quality. So there's a lot of limitations there. And I don't know that everyone's ever going to do the detailed research on that. There's a lot of different ways to nutritionally meet your basic needs, and that's really what I try to focus on with people. We don't have to do it in one specific way. It's not my way or the highway. I want something that feels sustainable for them, and being able to review their specific supplements, review the foods they like, what's working for them, what's not, allergies and tolerances. It becomes very individualized, and that's the purpose of the work we're trying to do. We want it to feel like an individualized treatment plan for everybody.
One serious question: will sticks and stones break my bones?
I haven't seen your T-scores.
Okay, all right. I want to know. How does someone get into your clinic?
So generally by referral. So
Okay.
the most common ways that folks are referred to me are through their primary care doctors, through the hospital medicine team or the emergency department team if they have been seen for a fragility nature fracture. Or actually one of my largest referring bodies is OBGYN. Many people, women do their...
Yeah, they use their primary care as their
Yep.
OB. Yeah.
They use their OB as their primary care, but also they offer in-house densitometry services. And so many of the OBs are the ones that are discovering the variations as far as, the osteoporosis, treatment potential, need there. There's 4 basic ways to get to osteoporosis. So one of them is a low trauma or no trauma fracture of the hip or spine. If you fall from standing height and you break your hip, that's osteoporosis, according to the WHO. If you have very low T-scores, those T-scores represent the number of standard deviations of bone that have been lost. If you've lost more than 2.5 from a young normal, then you meet the criteria. If you've lost some, let's say you meet the criteria for low bone mass, used to be called osteopenia, but you've had a fragility-related fracture, wrist, the upper arm, perhaps, a rib, those also meet the criteria to be elevated to osteoporosis treatment. And then finally, if you have somebody who has a high fracture risk. So that's what we call the FRAX or the 10-year probability calculator.
Okay.
If we calculate your 10-year probability to be greater than 3% at the hip for a fracture or 20% for what's called a major osteoporotic fracture, which is, the upper arm, the spine, the hip, so forth, then that also elevates your treatment risk to osteoporosis from the standpoint of, ICD-10 coding. And from a risk standpoint, you need to treat that as though it's osteoporosis.
Oh, that's good information there. Why did you choose this to start this up?
Yeah, absolutely. So I have a 10 plus year now, a background in orthopedics and had worked for the last about 5 years in neurosurgery, where I was taking care of predominantly women, but women and men that had fragility fractures of the spine. Some of them were traumatic, but often they were low trauma, no trauma. And it really inspired me to learn more about bone health and osteoporosis. Not only how do we protect the woman who's sitting in front of me, how do I protect her daughter that's sitting next to her that's 20 years younger? What can we do to prevent that first fracture? So my background was actually, I was an engineer. I think you maybe knew that about me. And I studied industrial engineering. So biomechanics have always been interesting to me. There's a lot of living biomechanics in bone. In addition to that, though, both of my grandmothers had osteoporotic hip fractures, one of which died from delayed complications within the year after her surgery, and the other one was never able to be repaired. And so she's still in a nursing home to this day. She never walked again. And so I know firsthand, what it feels like to have that not only in my family, but also to see the potential risks and complications of it. And, for, even one fracture risk reduction, I would have done this 10 times over. So
it always amazes me, and still does, how one person can have a compression fracture and the x-ray looks horrible and they're like, man, it doesn't even bother me. And another patient can have some very severe persistent pain to the point of disability. So it's preventing it. It's probably the key to treating this disease, isn't it?
Yeah. And it's not just the pain. We think about and we worry about the pain, but, people who have multiple vertebral fractures, they lose up to 10% of their vital lung capacity for every kyphotic fracture they have.
Really?
I mean, there's
makes
huge
sense. I didn't know what the number was, but wow.
Yeah, there's huge respiratory potential complications there, but there can be worsening back pain as well with the postural things. There's a number of factors that can come into play, but yeah, preventing that first fracture is always the goal. But understanding that if someone has suffered a fracture, whether it is hip, spine, wrist, that transforms their relative risk in such a way that it's an exponential increase. So if you have one vertebral fracture, you're now mathematically 4.4 times more likely to have a second one. So if we were, estimating your risk correctly before, we're massively underestimating your risk now.
Okay.
And that's part of what I go through with folks to try to explain that, unfortunately, there are just those people that will fracture, even at the same numbers, There's some that are more likely. And if someone is falling, we're almost always underestimating their risk. And I consider that to be one of the gold standard of things that we have to address, because, falls still cause 90% of hip fractures.
Yes.
The best medications won't make a person bulletproof.
Right.
So we have to, do everything that we can to avoid falls.
Yeah, that's so true. Well, Abby, thanks for joining me. This is really interesting. I learned a lot today. It's been great information. Once again, this was Abby Crow, a nurse practitioner at UnityPoint Clinic, Endocrinology, Diabetes Care, and Healthy Living Clinic. For more information, visit unitypoint.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.